Leishmaniasis affects as many as 20 million people worldwide, with 1.5 million new cases each year. Leishmaniasis is transmitted in many tropical and subtropical countries and is found in parts of about 88 countries. Approximately 350 million people live in these areas. The settings in which leishmaniasis is found range from rainforests in Central and South America to deserts in West Asia and the Middle East. Visceral and cutaneous leishmaniasis are distinguished. Visceral leishmaniasis. The following variants are distinguished: Mediterranean infantile, Kala-Azar, Indian Kala-Azar, East African, Chinese, and American leishmaniasis. The visceral form of leishmaniasis has an estimated incidence of 500,000 new cases and 60,000 deaths each year. More than 90% of the world's cases of visceral leishmaniasis is transmitted in many tropical and subtropical countries in India, Bangladesh, Nepal, Sudan, and Brazil. Visceral leishmaniasis is caused by various species of Leishmania donovanii. Various rodents, dogs, cats, monkeys, and human beings are susceptible to Leishmania. The source of infection in the Mediterranean littoral leishmaniasis are dogs, jackals, foxes, possibly rodents. The source of Indian Kala-Azar is a human patient, while the source of East African variant are humans, dogs, jackals, foxes, and rodents. Sand flies of the genus Phlebotomus are the vector of the infection. After sucking blood from infected human or animal, female sandflies can transmit the infection in 6–8 days. Mediterranean littoral leishmaniasis afflicts mainly infants aged from 1 to 5 years. Indian and East African visceral leishmaniasis affect humans of all ages, but young patients dominate. The portal of entry of Leishmania is the site of sandfly bite. The bloodstream carries the microorganism to the cells of mononuclear phagocytic system of the spleen, liver, bone marrow, and lymph nodes to cause their dysfunction and damage. Some cells die. It is attended by the proliferation of the mononuclear phagocytes, which causes degeneration of the spleen, liver, and lymph nodes. These organs become enlarged and firm. Their function is upset. The gastrointestinal tract and the kidneys are also involved. Destroyed Leishmania and their metabolites cause toxemia and upset metabolism in the macroorganism. Some patients develop a papilla in the portal of infection. The incubation period of Mediterranean leishmaniasis is from 20 days to 3–5 months and longer. Of Indian Kala-Azar, 6–8 months on average. 3 periods are distinguished in the course of the disease: initial, clinically manifest, and terminal. The onset of the disease is gradual. The patient develops fatigue, malaise, and subfebrile temperature. His appetite is impaired. The skin and visible mucosa are pallid. When the disease is in its full swing, the temperature curve is irregular and undulant. Rises of temperature to 39–41 are followed by afebrile periods. Body temperature fluctuates not only within few days but also within 24-hour periods. Temperature variations are attended by chills and sweating. The spleen is firm and enlarged from the first days of the disease. Splenomegaly becomes striking with time. Its lower edges descend to the navel and even lower. The liver and the peripheral lymph nodes are also enlarged. The skin is pallid. Anemia develops in 2-3 months. It progresses as the bone marrow is involved. Granulocytopenia and agranulocytosis are characteristic. Hemorrhages into the skin and mucosa are possible. Epistaxis and gastrointestinal bleeding occur. Splenohepatomegaly causes portal hypertension, ascites, and edema. In most patients, the red blood cells count is low. Leukopenia, neutrophilopenia, and eosinophilopenia with relative lymphocytosis and monocytosis, and also thrombocytopenia are characteristic. The serum albumin is low, while the globulin content is high at the expense of alpha and beta globulins. ESI is high, 50-90 mm per hour. In the absence of timely specific treatment, acute forms of visceral leishmaniasis transform into subacute and protracted forms of the disease. The skin becomes pale gray. In Indian Kala-Azar, the skin is dark, almost black. Kala-Azar in Hindi means black fever. Edema increases. Diarrhea supervenes, often with admixture of mucus and blood. The terminal period is marked by cachexia, marasmus, low muscular tone, frog belly syndrome. In the absence of adequate treatment, the disease lasts from 1 to 2 years. Kala-Azar and East African visceral leishmaniasis are characterized by nodular and macular rash, cutaneous leishmanoid, which develops in 1-2 years after the onset of the disease. Kala-Azar and after clinical recovery, East African leishmaniasis. Patients are persistent sources of infection for years and even decades. The diagnosis is based on clinical, epidemiologic, and laboratory findings. Isolation of leishmania in smears of sternal marrow, lymph node biopsy, and less frequently blood is decisive. The material is also inoculated into NNN medium for growing leishmania cultures. Serologic tests are also used. Inoculation of hamsters is also used in biologic studies. The specific remedy against visceral leishmaniasis is solusurmin, solustilozan, stibanol, pentostam. If secondary infection supervenes, antibiotics should be given. Transfusion of blood and erythrocytes and also vitamins are indicated for anemia. Prevention and control leishmaniasis measures should in the first instance be aimed at elimination of the source of infections. These include extermination of jackals, foxes, stray, especially diseased dogs. Veterinary supervision of dogs in endemic areas is necessary. Timely treatment of visceral leishmaniasis patients with specific preparation is necessary. Protection against flying insects is important too. Improvement of populated places helps eradication of insects and sites of their propagation. Closure should be treated with insecticides. Population should be protected from insect bite by repellents and other means. Cutaneous leishmaniasis. New World and Old World cutaneous leishmaniasis are distinguished. The Old World form divided into two distinct types, an urban anthraponotic form, dry leishmaniasis, having an incubation period of many to over a year, and lasting for many months, and acute rapidly evolving zoonotic form, known also as rural, humid, moist or wet cutaneous leishmaniasis. The causative agent of anthraponotic cutaneous leishmaniasis is Leishmania tropica minor, and of the zoonotic form Leishmania tropica major. The source of anthraponotic leishmaniasis is a human being, while in zoonotic forms these are wild rodents. In nature, the causative agent circulates in the system: diseased rodent, sandfly, healthy rodent. The transmitter of leishmania are female sandflies of the genus Phlebotomus. Anthraponotic leishmaniasis occurs as sporadic cases in towns and cities during the whole year, which is due to various incubation periods. In the zoonotic form, the incidence of the disease increases during the warm season. It occurs only in rural areas. Anthraponotic leishmaniasis occurs in the Middle East, South Europe, India and Africa, while the zoonotic form in Asia, Africa and South Europe. Leishmania enters a human through a bite of an infected sandfly. After inoculation into the skin, leishmania propagates at the portal of entry to form infiltration. In the anthraponotic form, the papules ulcerates in 3–6 months, in the zoonotic form in 15–16 days. The incubation period of the anthraponotic dry form is 2–8 months, 2 years and more. In the zoonotic moist form, it is from 1 week to 2 months. Cutaneous leishmaniasis affects the face, the neck, the upper and lower extremities, less frequently the trunk. The quantity of ulcers corresponds to the number of bites by infected sandflies. The dry form is characterized by development of a pink papula at the site of sandfly bite. In 5–6 months, the diameter of the papula is 1–2 cm. The papula is later covered with scale and then crust, and in 6 months it is affected by necrosis with ulceration. The ulcer diameter increases and can be 4–6 cm. In few months, the ulcer begins healing and a scar is formed in a year. The papula in the wet form is scarlet, looking like a furuncle. In 1–2 weeks, the center is necrotized, and ulcer is formed with a diameter of 2–5 cm. It is 1–3 mm deep and has irregular shape. New nodules are formed around the ulcer, which later are necrotized too. The ulcer fuse into a large ulcer with a diameter of 10–15 cm. Copious serapurulent exudatic dries into a dirty gray crust. In 2–3, sometimes 4–6 months, the ulcer undergoes epithelialization and cicatrization. During 3–6 weeks, scars remain after healing. Cutaneous leishmaniasis is diagnosed on the basis of clinical and epidemiologic findings. The laboratory method is also important diagnostically. Smears for laboratory studies are prepared from the exudate, which is expressed from a punctured nodule. The cutaneous form is treated by local application of solusurmin. The preparation is given under the nodule or in the vicinity of the ulcer. Intracutaneous injection of monoamicin and quinacrine around the ulcer is also helpful. Severe cases should be treated with solusurmin, like in visceral leishmaniasis. For prevention and control of disease, it is necessary to reveal timely patients with cutaneous leishmaniasis. Patients with ulcers on exposed parts of the body should wear dry bandages. Deratization is obligatory. Population should also be protected from sandfly bites. Whenever necessary, all enclosures should be treated with insecticides. Means of individual protection should be used repellents, netting and gauze against flying insects. Specific prophylaxis is performed with a live culture of leishmania. The New World form. The disease is known by different names in various countries. Among more common names are American, Brazilian, or mucocutaneous leishmaniasis. The disease is caused by Leishmania brasiliensis. The reservoirs of infection are rodents and domestic animals. The transmitting vector are sandflies of the genus Phlebotomus. Unlike in other forms of cutaneous leishmaniasis, in American leishmaniasis the mucosa is involved in 1-2 years. This causes deformation of the nose, nasopharynx, airways, genitalia, and the ears. The disease lasts from 2-3 years to decades.